This presentation was presented to the 5th Orthopaedic Manual Therapists Association Conference at the Triumph Hotel in Cairo, February 24th, 2023. It has been slightly modified for free online distribution. I would like to thank the Physio Academy for making it available at no cost. I'm sure you all know that low back pain is the leading cause of years lived with disability, and this has been documented since 1990. In 2017, the point prevalence globally was 7.5%. This means that over 500 million people have back pain at any given time. In industrialized countries, point prevalence can be as high as 15%. The number is increasing as population increases, obviously, but also as a result of an aging population. National guidelines for the assessment and treatment of back pain are available in most developed countries. While there are minor differences between interpretations of the available evidence. Okay, I'll leave it now. So, whatever happened to facetogenic pain, sacroiliac joint pain, discogenic pain, end plate and vertebrogenic pain? Don't these conditions exist? Well, yes they do. We do have criteria and standards of diagnosis to identify these painful conditions. However, the diagnostic interventions are expensive and to some extent invasive and require specialist physicians trained in the interventional methods needed to confirm the diagnoses. When I was asked to present a keynote lecture at this conference, I was mindful of the fact that I am not a professional academic, nor am I a full-time teacher. I am a clinician who has done some research, achieved some publications and done quite a bit of teaching over a 30-year period. So what I thought I should do is to give you a small window into what my day looks like. I took the last 2 clinic days of December last year and noticed that I saw 6 new referrals for back pain related conditions. I thought I would look to see which patients satisfied guideline-based diagnostic criteria, then see if I actually did arrive at a specific diagnosis the guidelines don't mention. The first patient was a 32-year-old circus arts contortionist instructor, an unusual profession. She presented with 3 weeks' history of sudden onset back pain whilst doing a familiar move while instructing. She felt a crunch in her back, and the pain was so severe she presented to the emergency department, who ultimately referred her to see me, as she did not satisfy criteria for surgical intervention or admission to hospital. She had a large right lateral trunk shift. My red flag screen revealed no evidence of quadriquinal lesion or other so-called serious conditions. My neurologic screening examination revealed no evidence of nerve root involvement, and the straight leg raises were over 130 degrees on both sides without provoking leg symptoms. She did have a past history of back pain episodes, and there was an MRI available from 2 years previously. Here you see discopathy at L4-5 that includes a posterior annulus tear that seems to be filled with nuclear material or some other fluid. The next patient was a 60-year-old female with 10 years of episodic low back pain. She was a poor historian and it was not easy to get a good history. However, she had a normal neurologic screening examination and the straight leg raises were also very flexible, reaching 130 degrees on both sides without causing any pain at all. On examining the sacroiliac joint and hip, I found no evidence of sacroiliac joint, hip or deep gluteal structures provoking pain. I concluded that she had either discogenic pain referring pain into the buttock and thigh, or she had facetogenic pain, possibly both. Here's a good question for you. Having ruled out everything but discogenic or facetogenic pain, does this enable or entitle you to classify this patient as being non-specific? A debatable point. My next patient was a 55-year-old female whose symptoms had been present for 1 week. The symptoms developed while walking. There was no trauma or special event. She was referred to me by the emergency department because there were no red flags and only weak evidence of an L5 radiculopathy, which I confirmed clinically. I referred her for an MRI which confirmed the clinical diagnosis of L4-5 disc herniation affecting the L5 nerve root on the right. I then referred her for a transforaminal epidural steroid injection directed to the L5 root, which was carried out about 12 days later. By the time she came to have the epidural, she had already started to improve, but by January 10, some 3 weeks after first presenting to the emergency department, she was essentially asymptomatic and discharged. My next patient was a 23-year-old female who presented on referral from the emergency department with dominant midline back pain, although the pain did start slightly to the right side of the lumbosacral junction. There were vague aching references into the hips and buttocks, but no evidence of red flags or neurologic signs. The visible left shift was rapidly reversible initially with manual correction, followed by self-correction procedures, followed by extension recovery, which she was taught and practiced in the clinic on the initial appointment, and continued as a home exercise program. This was her second episode, the first of which occurred 2 years previously. That episode was treated by 2 months of chiropractic manipulation, which did not appear to help her. She terminated that treatment and ultimately recovered spontaneously over a matter of another month or so. This patient clearly would be classified as having non-specific back pain according to guideline recommendations. However, the rapid reversibility of the condition with shift correction and extension recovery allows me to infer that the pain is discogenic in origin. The next patient was slightly more complex. She was a 46-year-old female with 2 seemingly different but closely related problems. She had been experiencing left buttock pain since age 18 that was less severe than the midline pains. These midline spinal pains in both the lumbosacral and mid-lumbar spine regions started some 5 months previously after jumping off a wall. The central back pain symptoms demonstrated a clear directional preference to extension, but the left buttock symptoms were unchanged by repeated movement testing. Ultimately, I came to the conclusion that the left buttock symptoms were arising from the left sacroiliac joint. She has been referred for confirmation of the diagnosis by controlled blocks. Another example of non-specific back pain according to the guidelines. The last of the 6 patients was a 32-year-old male who created this pain drawing. The right buttock symptoms were currently dominant, but he does describe left buttock symptoms as having been dominant at onset. He had alternating buttock pain. These symptoms had been present for many months, and his doctor had arranged blood tests revealing that he was HLA-B27 positive. I agree with his GP that he likely has an axial spondyloarthropathy. These 6 patients are typical of my workday. Most of them can be given a diagnosis supportable by published evidence. 2 had diagnoses narrowed down to 2 different possible entities. You could argue that because I was unable to separate out 2 different possible causes of symptoms at the initial consultation, these patients were non-specific. It is a debatable point, but I would not be impressed by the argument that diagnosis is not possible. Diagnosis is possible in all of these cases, in my opinion, and the less certain ones are in the process of having the diagnosis refined. Now I will give you my perspective on what non-specific really means as it relates to back pain. The first thing I want you to grasp is that non-specific back pain is not a diagnosis. It is what the patient presents with and asks you to assess and treat. Non-specific low back pain is a heterogeneous collection of multiple different possible entities, which include discogenic, facetogenic, vertebrogenic and sacroiliac joint pathologies as sources of nociception. These are the main ones which we know exist and have a known prevalence, established and reported in the literature. It is my view that a patient should be considered as having a non-specific condition before your assessment begins. As soon as you begin to gather data about your patient, the degree of uncertainty about diagnosis diminishes. The probabilities shift and change as you find out more and more about your patient. Specificity increases with knowledge and assessment. For example, an athletic, healthy 36-year-old woman whose back and dominant buttock pain that has been present since the 3rd trimester of her 3rd pregnancy 6 years ago has a much higher probability of sacroiliac joint pain than discogenic pain or facetogenic pain. Conversely, the 21-year-old builder who develops midline back pain that started 3 months ago lifting a 50-kilogram drop arm saw at work is far more likely to have discogenic pain than sacroiliac joint pain or facet joint pain. Non-specificity is not a target, a goal or a diagnosis. It is an admission of ignorance. It is where we start. At the root of scientific diagnostic clinical reasoning is the notion that the probability of a disease process is equal to its prevalence. These prevalence values come from De Palma and colleagues' report on a secondary care sample of back pain patients. The prevalence of discogenic pain has been estimated to be about 40%. The overall estimated prevalence of facetogenic pain might be as high as 30%. Some estimates of sacroiliac joint pain prevalence are as high as 18%. Radicular syndrome constitutes 10% of cases. A good place to begin acquiring data from patients is to have them complete a pain drawing. I have been using pain drawings since the early 1980s and now use a standardized color palette I copied from the late Dr. Charles April in New Orleans. Red indicates sharp stabbing pain. Yellow is deep aching and poorly defined pain. Blue is for hot or cold sensations. Black is for numbness and green is for paresthesia. Brown is for stiffness and other different symptom descriptions. This patient had discogenic pain confirmed by provocation discography. This patient had facetogenic pain confirmed by controlled diagnostic blocks. This 17-year-old patient had sacroiliac joint pain initially diagnosed clinically and confirmed by diagnostic blocks and sodium fluoride PET-CT scan. This patient had an L5-S1 disc extrusion impacting the S1 root, confirmed by MRI and at surgery. The pain drawings of each of these patients were produced by the patients themselves when asked to describe their pain. The first 3 patients will be classified as having non-specific low back pain according to guideline recommendations, and the 4th patient would be correctly classified as having radicular syndrome according to guidelines. Although the first 3 patients may be categorized as having non-specific low back pain according to guideline recommendations, they do have known specific sources of nociception. Just to give you an idea about how we begin deconstructing the concept of non-specific back pain, I will briefly show you how the probability of these different painful pathoanatomic conditions changes as you gather information about your patient. Let's take this patient with unilateral low back pain with some somatic referral into the buttock. Well, we start with the same probabilities as before. Even though this patient is still guideline classified as having non-specific low back pain, the clinical picture is different. Look what happens when we consider the clinical findings during our initial assessment. First, we noted that there is no evidence of a neurologic deficit. The probability of the patient having a radicular pain syndrome diminishes, and probabilities of other conditions rise accordingly. This patient only had one sacroiliac joint test that provoked familiar pain. So the probability of a sacroiliac joint pain problem diminishes accordingly, and the probability of the other conditions rises. When this patient was examined with a repeated movements assessment, there was no evidence of a directional preference. Therefore, the probability of discogenic pain is reduced by about half, because half of discogenic pain cases do have a directional preference. The effect on the probability of facetogenic or sacroiliac joint pain rises accordingly. When you compile the data available, you discover that the patient satisfies published clinical prediction rules for a positive screening facet joint block. This has a significant effect on the probability that the patient has facetogenic pain rather than anything else. Lastly, we consider this patient who has dominant pain in the right parasacral and buttock region. Again, the probabilities of the different pathoanatomic sources are the same before you assess your patient. In this case, there was no evidence of a neurologic deficit, and so the probabilities shift and change as it did for the patient with facetogenic pain. Again, the repeated movements assessment reveals an absence of the centralization phenomenon or directional preference, so the probability of discogenic pain diminishes, while the probability of facetogenic and sacroiliac joint pain increases. However, this patient was different from the previous one in that 4 sacroiliac joint pain provocation tests were strongly positive in the absence of the centralization phenomenon. The probability of a sacroiliac joint source of pain rises dramatically, while the probability of facetogenic pain diminishes. These are just samples of how scientific clinical reasoning is applied in real life. Our knowledge of the evidence and application of diagnosis by subtraction allows us to reject with some confidence the traditional notion that such patients have an unknown or unknowable source and cause of their back pains. This system is not perfect, but nothing is. There is much research to do to refine and improve what we know and understand at the present time. What we can and must do is to reject the notion that simply because a patient does not have a red flag condition or a lumbar disc herniation, the condition is by default non-specific and essentially unknowable. Not just unknown, but unknowable. We can and should be doing better than the current guidelines imply. Moritz van Tilde and colleagues published this book in 1999. It is my understanding that now there have been over 500 randomized controlled trials looking at non-specific low back pain treatments. It is now plainly evident that nothing has changed since 1999. More recent systematic reviews continue to find that different treatments for non-specific back pain, the symptom, have small or no effect when compared to each other, to natural history, or to placebo interventions. It is also clear that recurrences are not prevented by the interventions that have so far been studied. Some treatments work for some subsets of the non-specific spectrum, but not for others. Different treatments are appropriate for other subsets, and many treatments don't work at all. When statisticians condense the results into mean values, the good and bad results cancel each other out, and in the words of Ayn Rand, the black and white are lost equally in the grey of it. This is what Van Tilde told us in 1999, and what systematic reviews and meta-analyses have been telling us ever since. As someone once said, and falsely attributed to Albert Einstein, insanity is doing the same thing over and over again and expecting different results. The concept of non-specificity is a dinosaur from the 1980s, and the world's obsession with surgery and surgeons who are always seen as being at the top of the knowledge tree by non-medical folk. What can we do to put an end to this academic insanity? Perhaps we need to start here. The randomized controlled trial is the accepted criterion standard for evaluating treatment efficacy of any given treatment. I have reproduced here the flow diagram from the 2010 Consort Statement, which is the internationally accepted RCT design protocol. It is my view that the poor performance of all studied treatments for non-specific low back pain starts right at the enrollment stage. This model is derived from pharmacological research, where a specific disease process is treated with a specific molecule and compared to a placebo or a different molecule. You cannot simply transfer this RCT structure over to back pain and back pain interventions without some serious consequences. As I've said, back pain is not a specific or single disease process and has never considered to be a single disease. Therefore, enrolling non-specific back pain patients at the very beginning of this research paradigm will inevitably produce non-specific results. GIGO. Garbage in, garbage out. The assumption of sample and treatment homogeneity is implicit in the RCT structure, so it is important to realize that this assumption is automatically violated by enrolling non-specific back pain patients. We need to get rid of this non-specific concept as a research topic and start identifying cohorts of patients with known specific sources of nociception using reference or criterion standards of diagnostic workup. We must know what we are treating. We know that this is not easy, given the relatively low availability of interested physicians able to carry out reference standard diagnostic interventions. That is why we need to do diagnostic accuracy research in order to identify the predictors of reference or criterion standard procedures. It is my opinion that the medium-term future of low back pain research needs to be in identifying clusters of variables from patient characteristics that have the ability to identify known subsets of the non-specific back pain spectrum. This is not new, and I certainly did not invent the idea. This is what expert clinicians have been doing for nearly 100 years. Clusters of findings from demographics, history, and physical examination have been given names too. For example, the radicular syndrome consists of a cluster of clinical findings, such as a report of radicular pain that may be identified from a pain drawing. Radiculopathy is identified by a neurologic screening examination looking mostly for a segmental motor deficit, a relevant loss of a key tendon reflex, and neural tension signs that provoke the radicular pain. Symptomatic spinal stenosis is a syndrome identifying a condition afflicting the elderly mostly, who describe cauda equina-like symptoms without acute onset or evidence of massive disc herniation. And most importantly, the symptoms behave in a characteristic way. The classic neurogenic claudication pattern is distinguishable from the claudication described by patients with arterial vascular disease. Also, a routine X-ray can usually rule out spinal stenosis, where degenerative changes are mild or even moderate. Just about all patients with confirmed symptomatic spinal stenosis have advanced degenerative changes visible on plain X-ray. These are just some examples of test clusters that are embedded in our standard orthopaedic and neurosurgical training and are taught to all medical students and doctors, physiotherapists, chiropractors, and osteopaths. As you probably know, I can claim to have contributed to the evidence of what may be called a sacroiliac joint pain syndrome. These patients have dominant parasacral or buttock pain in the absence of evidence of radicular syndrome, and in patients whose symptoms cannot be made to centralize using McKenzie's repeated movement assessment, and whose primary pain can be produced or increased by at least 3 sacroiliac joint pain provocation tests. Patients with this cluster of clinical signs are highly likely to satisfy the internationally accepted criterion standard for intra-articular sacroiliac joint pain, which is controlled and guided blocks of the sacroiliac joint. We also published 2 papers on predictors of lumbar facet joint blocks as well. One was a test of an earlier model proposed by Dr. Ravel and colleagues from France. We could not replicate their results, unfortunately. However, we did our own analysis of our reasonably large cohort of patients undergoing facet joint blocks, and the results were published in 2006. The variables we found useful were age over 50, symptoms were best walking or sitting, location of pain at onset described as being unilateral, a positive extension rotation test, and the pain cannot be centralized using the McKenzie repeated movement testing protocol. Unfortunately, so far, no one has attempted to replicate, challenge, refute, or validate our findings. It is long overdue. What we found was that different combinations of these variables have high sensitivity and or specificity to lumbar screening facet joint blocks. Here is the point I wish to make now. If you can predict a positive or negative reference standard test procedure, there is no need to have the patient go through the expensive and invasive testing procedure. In my opinion, replicating, refuting, validating, or improving on these clinical prediction rules and developing new ones is the cutting edge of back pain research for physiotherapists. This is how we escape the limitations of the concept of non-specific low back pain. To conclude, I believe we are at an advanced stage in the development of our understanding of the nociceptive origins and causes of low back pain. Clinical diagnostics has evolved to a level where we may abandon diagnostic and therapeutic nihilism. We should now reject the notion of non-specific low back pain as a failed experiment. Diagnosis is possible for the majority of cases using minimally invasive and expensive specialist physician procedures and protocols, but it is not needed for a large proportion of the patients seen at both primary and secondary care. Clinical diagnosis using readily available information about the patient and a decent clinical history and physical examination is already good enough to start categorizing patients into pathoanatomic subgroups within the back pain spectrum. It's not perfect and it probably never will be, but it is sufficient to guide the use of reference standard diagnostic interventions and management protocols. The methods used for reference standard and clinical diagnosis are scientific and have a solid scientific evidential basis that has evolved over the last 30 years. I urge you to learn how to categorize your back pain patients in this manner. We can do so with a known degree of confidence and without any pretense at omniscience. Patients frequently want to know the source and cause of the pain. Being able to explain the probable reasons for the pain in answer to this reasonable question is of great value to the patient and to you as a clinician. Although we do not have many treatments with proven efficacy for many of the subcategories we now know to exist within the back pain spectrum, we do know enough to vary our treatments appropriately and scientifically. The clinical diagnostic methods that you can learn may also guide your recommendations to your patients and clinical colleagues when more invasive and expensive diagnostic interventions are required. I believe we can state with some confidence that there is light at the end of the tunnel. We no longer have to try and explain to patients that there is no known cause for their back pain. We can look forward to the time when the technology and methods have been explored by new research paradigms that may provide us with much more targeted and specific treatment options for patients with specific causes of back pain within specific spinal structures. Thanks for your attention. Please share this presentation as widely as you like, but please don't modify it and acknowledge the source of the ideas. If you want to update your skills in lumbar spine diagnostics, log into the Physio Academy and register for my courses. These courses are structured to suit any level of knowledge and experience. The new graduate or student can start with Back Pain 101, which takes the first steps beyond guideline assessment and management. My full clinical evaluation from history to the physical examination is covered in detail in Back Pain 201. The use of validated questionnaires is also covered in some detail too. There is nothing weird or difficult in my assessment. Any clinician can learn this and become proficient. For those of you who have completed Back Pain 201 or who have years of experience, the Back Pain 300 series takes you on a journey where you will learn to diagnose and treat different subsets of the back pain population. Back Pain 301 covers mechanical discogenic pain. Back Pain 302 covers the radicular syndromes from diagnosis through conservative management to use of epidural steroid injection and surgery. Pre- and post-surgery management is also covered. Back Pain 303 covers diagnosis and treatment of pelvic girdle and sacroiliac joint pain. Back Pain 304 covers diagnosis and treatment of facetogenic pain. Back Pain 305 covers diagnosis and treatment of back pain in young athletic patients, including spondylolisthesis, posterior column bony stress reactions and fractures. Back Pain 306 covers diagnosis and treatment of non-mechanical discogenic pain and vertebrogenic pain disorders such as those that are seen on MRI as modic changes. All courses have extensive video of actual patients seen by me in my clinic with follow-up assessments and treatments to the extent that is possible. Some follow-ups extend out to 5 or 6 years. All courses review the available evidence to support assessment, diagnosis and treatment to the extent that evidence is available. Where evidence is thin or lacking, systematic and non-systematic reviews are presented to give the clinician up-to-date information. These courses are evidence-based and reflect my commitment to research and teaching. Please join me in what I believe to be an exciting journey of discovery.